Thanks everyone for joining. We'll get started in a minute or two once folks have logged in. Thanks so much. Okay, I think we'll go ahead and get started. I'm Chrissy Giuliano, Executive Director of the Big Cities Health Coalition. Let's go to the next slide, Gabby. The Big Cities Health Coalition is a forum for leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the nearly 62 million people they serve. So you can see the map. Thanks everyone for attending today. We're really excited to have another one of these discussions. Let's do some housekeeping. So the session is being recorded. The link will be sent out and it will be on our website. All of the lines are muted except for the speakers. If you have any technical issues, you can use the raise your hand function, or you can also chat Gabrielle Nichols in the chat function. You can also ask questions in the chat function and we'll be able to see that. So I'm really excited to have Dr. Muntu Davis here with us today. He's the health officer in Los Angeles County, California. He was previously the health officer and director at the Alameda County Health Department. He's practiced medicine in urban and rural primary care and urgent care clinics throughout California. Dr. Davis received his medical degree from UCLA and completed a residency in family medicine at Presbyterian Intercommunity Hospital. He also completed a California Endowment Scholars Program or Health Policy Fellowship rather, and received his Master of Public Health degree from Harvard School of Public Health. So thank you so much for being here today. Really appreciate your time. We're going to take the slides down so that we can just chat. There we go. So we're here today to talk about COVID-19 as part of our webinar series. But we wanted to take a couple minutes at the beginning to talk about some of the protests that we've seen coast to coast over the past few weeks. I know your colleague, Dr. Ferrer, who runs the health department, spoke about the connection between police brutality and African Americans and the disparities we've seen in COVID. So as a health official in one of the largest cities and counties in the country, what are your reflections on what's going on right now?
Thanks for the question. And again, thanks for having me. It's interesting. I was here in Los Angeles at the time Rodney King sort of protest and went about in Los Angeles, and it was a very different scene at that time. However, as I reflect on many of the things that I've seen over the years, it just seems to be that increasingly we see more instances of either police violence or people dying at the hands of law enforcement, or issues of not necessarily overt racism, but other racism sort of coming into play as we look at the way things go about and outcomes that we see. And I was asked this question about whether or not this is a public health issue in terms of what's being called police violence. And when I think of some of the criteria you have to think about for public health issues is, one, what's the impact that it has on health? Two, is there some way to intervene? Three, does it have the ability to expand to another population and cause some of the same serious health outcomes? And when I look at the incident with George Floyd, there was nothing in there that seemed to be a threat from what most of us saw. And I think the reason has sparked such outcry amongst not only the community locally, but across the US and across the world, is because I think people recognize that could have been any one of us. And that particularly is a concern. If you have something like that happen and it's unchecked and it has such a severe and serious outcome, even if it's on a particular group, it could be others as well. So I think it is something we have to pay attention to and something we have to figure out how we address, while at the same time being able to have law enforcement do the role that they're intended to play within our society.
So if we say racism is a public health issue, what is that? What's the obligation for health departments to address some of these issues? What are the some of the things that you all are thinking about doing that others can and should be thinking about doing?
Well, I think one of the most important things is to consider beyond healthcare and even within healthcare, what are some of the drivers for the health outcomes that we see and the disparities that we see. So as a health department, we typically are the one entity inside of a jurisdiction that is responsible for analyzing all of the population health data. And for California, we actually have a code and statute that says we're also supposed to talk about the social factors that are impacting health. So our role as a health department is to, one, say where the disparities are, and two, to try to glean not only from what we see in the data, but from talking with others who are experiencing this, who are working on these issues, to figure out what are some of the other sources or causes for what we're seeing in terms of the outcomes. And if we're not seeing changes or closing of those gaps, what are the recommendations that not only we would have, but others have raised that have a good chance of actually resolving, the issues that we're seeing. So we, in essence, have to paint the complete picture of what may be at play in terms of the disparities or the poor health outcomes that we see. And in some instances, I would say that you may see some disparate outcomes in policies and other things that, whether you said that they were overtly racist or not, they may have a disparate impact on one racial group versus another.
So there's been a lot of discussion nationally about how the protests and these large gatherings of people in cities, and not just cities, across the country may impact COVID. How have you all been addressing that?
Well, we have, given recommendations to protesters. We, completely support people's right to go out and actively express their opinions. We've, really stressed the use of face coverings to try to prevent spread to others. And if you were out and protesting and around a bunch of other people who did not have face coverings, that you quarantine yourself just to make sure that you weren't exposed and aren't going to come down with COVID and pass it on to someone else unintentionally or unknowingly. But we have, put out, guidance in relationship to that. We've also put out some guidance in relationship to law enforcement who might be interacting, with the public as they're protesting. As many of you may have seen, for California now, there and maybe in other places as well, there are no limits in terms of outside protests or outdoor protests. So we've done our best as a public health department to provide some information to help, make it as safe as possible.
Okay. So let's turn back specifically to COVID in LA County. So tell us a little bit about the trends that you're seeing and where you guys are at this point in the pandemic.
Well, as many of you have seen, we actually have the largest amount of cases in California. We are actually the largest jurisdiction, being almost 10.5 million people. Our numbers have been pretty consistent or come down on serious outcomes. So for deaths, we've started to see a decrease. For hospitalizations, we had started to see a decrease. We've reopened some things with protocols in place to try to make them as safe as possible. And we continue to watch those serious outcome numbers as well as the case numbers. Now for the case numbers, we still hover at around the same off the course of a week. However, we are seeing an increase in the number of people who are being tested that are positive. It's not a rapid increase, it's a little bit of a slow creep. And we're trying to stress what people need to do, what organizations need to do to support people to be protective and prevent COVID from spreading when people are out and about.
So you mentioned that the county is starting to open up a little more. How do you thread this needle between keeping people as healthy and safe as possible, but then also telling them they can start start to restart some semblance of, their normal lives?
So let me first say that our society was never set up for people to really be at home for even a month. And, the support, whether it's financial or even freezing of all financial transactions like rent or like mortgages or like payments on cars, we weren't set up for that. But as we've looked at, the stability of our numbers, and as we've looked at places that could reopen that may be less risky, again, thinking of like a concert with an audience as being a very high risk location and a place that can't modify as much. We have specifically included in our health officer order protocols that must be followed. And part of the reason for doing that is to ensure that the workers who are there are protected. And those are the folks that are providing the services, the basic needs, and others that we all would want to have or need. So we use our orders to make sure that there are protocols in place to protect them, meaning that people who are entering into the building have to abide by certain rules, and the people who are working there have to abide by certain rules, as well as the employer supporting them in terms of keeping themselves safe, keeping their workers safe.
So I maybe shouldn't admit this on a webinar with 80 public health people, but I ate outside at a restaurant last night with my family for the first time in 13 weeks, but who's counting? And it struck me that I was sitting at a table unmasked, but I was being served by people wearing masks, but they were exposing themselves to me. And I've had a lot of discussion with my children about essential workers. I don't, restaurants, essential workers, but people who can choose to stay home and people who can't. So it was just a concrete example of some of the issues that we're all talking about and thinking about, how to, again, keep people as healthy and safe as possible.
And I will say, just to add on that piece, when we look at a sector to reopen, we try to think about what is the risk, what is the client or the customer going to be doing, and what is the employee going to be doing. And so if you look at our protocols for restaurants, it's a little bit different. So for the people serving you, because we recognize that the clients or customers aren't going to be wearing face coverings, we require that the servers actually wear face shields. So another layer of protection, which is not common in other places. And so we try to use, again, those orders to try to figure out what makes the most sense in order to protect those who are going to be there.
Yeah. So, LA County, like many large jurisdictions across the country, is really diverse. So how does that affect what you need to do in a response like this?
Well, we definitely have to pay attention to, race and ethnicity data. Many communities specifically want to know about what's happening with their community and their neighborhoods or their cities. So we make sure that we do as much of that breakdown as we can based on the data that we have and that we can collect. The other is as we've seen disparities, related to lower income neighborhoods or communities of a higher proportion of color. We have looked at the data and tried to figure out and understand that in many of those locations, they're under-resourced. So we try to share that data with those who have the ability to provide those resources in those locations, like testing, like making sure that we just started doing an FAQ for employees so that they know what to expect going back to work, recognizing that it cuts across all communities, but for a lot of the essential jobs that we talked about, those that were operational when everything else was shut down, we have a lot of lower income, workers in that realm, as well as communities of color who are experiencing severe outcomes like death and hospitalization. So we really have to pay attention to that. And for a lot of our information, it's translated into a number of different languages to ensure that it's in the language that people understand best. And hopefully they get what they need to make the best possible choice in their
lives. So we've heard a lot about mental health of frontline workforce. In the media, it's mostly been focused on doctors and nurses in hospitals. But we also know that there are real implications for governmental public health staff and folks who have been working 24/7 for 4 or 5 months now. So what have you all been doing, both as leadership, but then also for the staff in the health department to address people's mental health, their full health?
That's a great question, and we've tried to, in instances where we can, sort of say, okay, you are off. Our staff is very dedicated and hardworking, as many of our staffs in all the public health departments, and they really want to do what's right. But at the same time, sometimes you get caught up in doing what's right in terms of the work, but don't take care of yourself. So we've been conscious to try to make sure that when we see people are working, a lot of hours, to say, okay, you're off for this time. I don't even want to see or hear from you, not even an email. The other thing that our county has done is paid for accounts for some of the apps that are related to mental health, meditation, relaxation, other things, that allows for everybody to have some resource even throughout the day that they could use, to take their minds away and try to relax for a few seconds, few minutes, whatever it may be at any point in the day. But we have also said, okay, well, now we got to start vacations. Like, we've been working too long in terms of this time. Vacations can now come back to play. Bureau directors work with your staff, figure out what that means. But we lifted that, and so we want people to get back to doing what they need to do. The other thing that we did was we made sure that anybody that could work from home was able to do so. One, to take out the stress and the fear that they may have in terms of being at work, but also that connection with family, which for most of us is really a good base for keeping us grounded in the work that we do.
I wouldn't mind a few days away from my family at about this point in time, but we won't repeat that. So there's a question here about a second wave, and so you and I discussed this a little bit this morning. There's all this discussion about, has the first wave peaked? Wave peaked? Will there be a second wave? What about a vaccine? What about flu season? So how are you guys thinking about all this, preparing for the fall while still really actively responding also to coronavirus?
Well, I don't believe there'll be a second wave necessarily. I think we're going to see a constant, in terms of new cases being identified, probably throughout the summer. Now, if that drops off, then maybe we'll see a second wave. But as places start to reopen, there's the chance that more people will come into contact with others who may be positive. And if people really aren't adhering to the physical distancing, as well as the face coverings, hand washing, other things, the same basic things that we've been talking about, it may prolong what we see in terms of COVID-19. But I think this is almost a dress rehearsal for what winter is going to look like. Early on in COVID-19, we saw people who were just infected with COVID-19 even during flu season. Then towards the latter part of it, we started to see co-infection. So for us, I think we are preparing to stress the importance of influenza immunizations early on, so that it decreases the chance that people will have severe outcomes from having both infections, if that does, come about for them. So we really do also think that at least that the face coverings are probably going to be needed during that time as well. But I think by that time we'd have a change in our culture, and face coverings and distancing are just going to be a way of life. But we'll see what the summer looks like. But I think it's still going to be a slow churn, and we'll just have influenza on top of
it. So thinking about the fall, again, reopening, what are the couple of things that either keep you up at night or that you would really highlight, for folks in other parts of the country who are also thinking about their current and future response?
As the thing that worried me most about reopening was that people would get a sense that there was no virus anymore, and that there was no reason to take the precautions that we are consistently recommending. And in that, we've tried to sort of stress that message. Even though things are reopening, the virus is still circulating within our community, and you still need to take these precautions in order to limit the spread, amongst your family or to other people. And so we often are looking at, how much are people thinking about others in terms of what they do, recognizing that face coverings are really about source control. Should you happen to have the infection, that you don't spread it intentionally to others. And then people arguing about, well, it's my right to not wear a face covering. Whereas in public health instances, you really are taking your choices, which will impact others. And what we are doing is really protecting each other and not just ourselves. So making sure that that message remains throughout this time is really the thing that keeps me up, and people not to let their guards down.
And do you feel like that message is getting through?
There's it's when you've got, honestly, when you've got things that come from higher up that say completely different, that it's all over, and that if we just stop testing we won't see any more cases. If we stop testing, no, we won't see any more cases, but that doesn't mean that it's over. So we're sort of battling between what some are saying and what we're seeing in terms of the data, and people often will take what fits what they believe, and that can be scary in this instance. But we hope people are paying attention to the real data and taking our recommendations.
So we have a question about contact tracing, which shockingly we've heard a lot about in the media. This is something you and the rest of the field has been doing for years. But what are you all doing around contact tracing and COVID?
Well, it hasn't stopped, from since the beginning. It's one of the core strategies that's needed in order to slow the spread of this. It is mostly virtual at this point. We don't have any investigators going out and necessarily knocking on doors for every case or contact that has been identified. But we continue to do it. We've had to expand the number of people that we have in order to do it. So we have other county staff as disaster service workers who have been loaned to us for a period of time. We're talking with community-based organizations or considering how we can add their expertise to help support people who would be in isolation and quarantine. But contact tracing is continuous for us. The thing that I think has been problematic with contact tracing is really just how quickly labs get to us. As many of you have seen, the turnaround time for a positive test can be anywhere from 24 to up to 10 days for some labs. And that's really caused issues for us to be able to do contact tracing very quickly. But it's one of those things that we continue to do, but it does rely on a number of others for it to be successful.
So there's another question here about children as carriers or spreaders. There was a CDC story, research out yesterday about this as well. So talk a little bit about that, maybe in the context of where we're heading on schools and things like that. We won't quote you on whether or not schools are going to open, but clearly it's on everybody's mind.
We're trying to figure it out. It's a great question. There's, of course, our pediatric centers are doing testing for COVID-19, and so we get a little bit of a sense from them, what we're seeing. But we're also trying to do a serologic study with children. So as we invite adults to figure out whether or not people may have already had it, whether they were diagnosed or not, just to get a sense of the prevalence in our county. We'd like to focus in on having families with kids also allow their kids to be tested, so we can get a sense of what it looks like for the school-age population where possible. It doesn't change maybe some of the recommendations that we might put in place for schools once they reopen. The one thing that's hard with schools, yes, the question of whether or not they're carriers and asymptomatic is going to be on everybody's mind, and we'll learn about, hopefully, as we get through the summer. But the question of whether or not face coverings, limit the child's ability to develop socially, to sort of see facial expressions and understand that, are things that also come into play. And we continue to talk with our educators about that to see what might be best, and at the same time, keep their optimal learning environment as close to what's needed as possible.
And whether or not kids will keep face coverings on throughout the day.
Right.
I've been trying to socialize my children into this is going to be the new normal, so get used to it. They don't really like it.
Get the fun face coverings.
Yes, I did tell them that if our schools do open, I will get them fun face coverings instead of just the blue ones that I've gotten them. So
Yes.
there's a little bit of bribery going on there. So if there are any other questions, folks should feel free to put them into the chat. Could children use face shields versus masks? Somebody just put that in now. I don't know.
Yeah, so the difference, so a face covering really does, it's over the nose and the mouth, so it really does limit the droplets from the person wearing it from getting out into the environment or onto others. A face shield is away from the face and allows for stuff to go down and around. So in terms of protecting the wearer, a face shield is better at protecting a wearer from droplets that may just sort of be expelled from someone else. But the face covering really is the thing that prevents them from potentially spreading to others. So I don't think that they're equivalent, and so I can't say I wouldn't say that they could be switched out, depending on if you're trying to protect others.
Okay, so there's another question on contact tracing and delays in testing results and varying degrees of mistrust in government. How effective do you feel that contact tracing efforts have been in identifying close contacts? And are more people refusing to give contact names than you would have thought, or how is that working?
Yeah, I mean, I think that's something we've run into even before, where we're trying to do is to prep people ahead of time. And have the providers, as they talk to people, to really say, hey, here are the things that you need to follow, and know that the public health department is going to call you to gather information and give some additional instructions to help you prevent spreading it to others. And we'll see if that improves things, but I recognize that as you go into a provider's office, and if you have one of those diseases that has to be reported to the health department, providers don't often say that. And so when you get a cold call from a number you don't know, or from a department that you aren't expecting to hear from, that may not be the best way. And people have some cynicism in terms of scams and other things that are going on. And so we're trying to figure out how to address that, but we don't have the perfect answer at this moment. But starting with the providers to give their patients a heads up that we're going to be calling, hopefully will help to alleviate some of the concern that they may have.
Yeah, there was a story, there's been some stories in other areas where folks have been saying, if you see this on your phone, that's us trying to contact you about COVID. I mean, I often don't pick up my phone if I don't know the number, but maybe I should change that in this new world. A totally unknown number is calling me right now. So somebody is asking how different local health departments of different populations are coordinating, in light of both response and then different conditions from jurisdiction to jurisdiction, and sort of what issues came up related to that for LA.
Well, we have once a week, or twice a week actually, I think it changed to once a week now, calls with our Southern California health officers, as well as our state organizations, to sort of hear about what's going on, what challenges they're running into. And I would say that initially we were pretty similar. We of course had a larger proportion of cases than they did. But otherwise, we're running into the same issues, and we share on that. We recognize that we may be a little bit different at the moment, and each of us understands why we're different based on local circumstance. But it's been great to be able to talk with others, to sort of hear from them and learn from them, and in many instances be supportive, and where possible be very similar, in order to reinforce what needs to be done in the same way. recognizing often that people will live in one jurisdiction and work in another. That consistency is helpful.
So somebody asked a question that you sort of just touched on. Are there specific issues related to COVID that make LA County different from other metropolitan areas?
I don't necessarily think so. We have a significant number of people, a significant number of businesses in each sector, maybe many more than others. I sort of joke about it when at one point there was the ability to open up home furnishing stores. And for us as LA County, we said no, that we aren't ready to do that yet. But for one of our city jurisdictions, they said, yeah, we're going to do it. We only have one. So that scale is very different. So when you're a large jurisdiction or a metropolitan jurisdiction, you may have many more of what you have to pay attention to than a smaller jurisdiction, which is maybe why you're more restrictive, just because it's just a lot to manage at one time. And the scale requires much more attention as well as many more resources to do it.
And so you're the health officer for all of the county, right? And there's something like 100 and change some odd cities within the county. So are all of those cities under the same order that you've issued, or are there now differences depending from city to city?
No, there aren't differences. There are two city health jurisdictions in Los Angeles County. That's the city of Pasadena and the city of Long Beach. And both are great. We have great working relationships with them. But our state requires that even for a city health jurisdiction, they can't move faster than the county. And the idea is that if you do have that, it's not as if COVID has really insular, meaning there are not walls around each city and COVID doesn't cross boundaries. So in order to have consistency across, better for the county as a whole to move. But we definitely work with them and talk with them and understand what issues or challenges they have. And we try to collaborate so that we're consistent and supportive of each other's actions, and they're pretty similar. But at the city level, where the city health officer, they have the ability to manage what's there, doing their investigations, et cetera. But it requires a good working relationship, and we have that here.
So you mentioned the state, and we have a question here about what role the state health department is playing. This is one of the places where maybe being a really big jurisdiction is different than, some of the smaller ones in your interactions with the state. So what does that look like?
It's interesting. So the state sort of set the floor for what, everybody, could do. So there was really a stay at home across the state. And once that order is in place, we as local health officers, local health jurisdictions have to follow that. And the state also, as it moves forward, allows for certain things to happen. In this particular instance, because we have a large number of rural jurisdictions that really didn't have a lot of cases, there was this challenge of how do you at a state level, try to manage the incident and have, some consistency where it made sense, and where could there be locations that could move forward a little bit quicker. So what the state did was to create what's called a variance, meaning if you could meet certain criteria, your situation looked in a certain way, that maybe you could advance beyond what the state had allowed with state approval in that regard. So the state has been very good and supportive on that regard. We have asked for a warning before you open up something, give us some time so that we can look at our situation and figure out what we need to do. Because as the local jurisdiction, we are responsible for implementing more restrictive orders if need be based on our local situation. And they've made that pretty clear across the state that you have to rely on your local health officer in order to say whether or not you can move forward if you have received a variance from from the state, excuse me.
My mute didn't unmute. So I don't know if you want to go on the record on this question, so I may soften it a little bit. There's a question about future lockdowns. And, if we're going to need to go back there. My husband and I have this debate every day as we see numbers going up of people leaving their houses. what do you think the appetite is for that? And, sort of where would we have to get to go back to, sort of statewide lockdowns again?
There's no number set in stone. I think, there's a number of different data points that we're looking at. And, we share our view of what the situation looks like with our Board of Supervisors, our elected body. And they've been very supportive and understand, our recommendations. And so I think if we look at the business side of the world, many of them have been closed down for months, may or may not have gotten loans, have put in a lot in place as required by us in order to make it safer for them to reopen. Whether or not they have an appetite to close again, probably not. But I think if things look really bad, I think people will get that understanding, and that may mean that people are more comfortable with that. So I think the importance of sort of sharing what the situation looks like across the various data points, but giving our interpretation as a health department, as folks who've been looking at this, the trends, et cetera, and where our concerns are, really is what may change the view of people in terms of where we go, if we go back to lockdown or not. So really it is a collaborative decision in people's understanding, because even if you lock down and the public doesn't get it, they may not follow that.
Right.
And I know many of us struggle with, how do you require people to do stuff and then at the same time try to enforce it. And really we have to touch the hearts and minds of the folks that really have to do it. So we try to make sure that we're sharing, answering questions as much as possible, so people really get a clear picture of how we're viewing it and what we're seeing, and they have the same understandings.
Well, and I think, that's also where how you all communicate with the public really plays a role too, and breaking through sort of the either or framing that sometimes occurs in the media. Those of us like at the national level who talk to media have been trying to push this. It's not an either or. We need to think of it as, we're not choosing people's livelihood over their lives. We need a path forward, and, we need to balance that. And I think many jurisdictions have succeeded in putting that message out there and communicating effectively with data and shared sacrifice and so on and so forth. So there's a question about how accurate you think sort of the case burden is, both the case burden and deaths, both in LA and the country. There's been lots of talk about underestimates and things like that. I don't know if you have an opinion that you'd like to share on that.
They're probably underestimates. I mean, as we have looked from the beginning of this, and one of the most fascinating things about this is that this really is a new virus. It's not going away quickly. It's not like H1N1 that didn't have such severe impacts or impact as many people as this. And we are learning constantly, week by week, as we look at national data and international data. So if you think about it, when we started out, it was really about symptomatic people who traveled. Then it became, we started to identify people who were asymptomatic but had the infection. CDC changed and said 48 hours before you have symptoms, you can infect. So I think there probably is an undercount. There may be many others who are asymptomatic and have the disease and are capable of spreading it and would never get tested because they just don't know. So I think for that reason alone, it probably is an undercount. The question of deaths, I think, is also one that's hard. Everybody's not getting tested in terms of dying. If there may be a scenario that looks like they could have been exposed and may have had the disease, then maybe there is that testing that happens. So there's probably going to be an undercount there as well.
And can you share a little bit about why that matters? I mean, I think as a nation, we're sort of obsessed with the numbers, but there are some real implications, right, moving forward, why we need to know those things.
So the numbers, and I'm sure you're asking about the numbers, why we need to know those. Yeah. So, with anything, it's if you think of this like a business, you have to know what your numbers are to know what you actually can do and what the recommendations are moving forward. So the more that we have in terms of the accuracy of cases, the better we are at doing isolation and quarantine and contact tracing so that we can slow the spread or stop the spread, from having concentric circles. And the other is just to see what has been the larger impact. Are there some things that should have been in place, whether it's on the public health, business, or policy side, that could change what we're seeing? And I think we're learning from this, and we have to figure out what would we put in place should this come up ever again. And so having those numbers really gives us an accurate count of what actually happened and whether or not we're doing well, using those numbers as indicators for the impact of the actions that or the strategies that we've put in place.
Thank you. So somebody has a specific question about, have you noticed if a particular social media tool, broadcast, or other outreach tool has been more or less effective in getting people out to get tested?
I can't say that we have, by data, noticed that one tool is better than the other. The one tool that we know works is person-to-person discussion. You know, when you hear something from a trusted friend, partner, you know, about what you should do, then that's usually what is going to drive people. Interestingly, back during H1N1, when I was in Alameda County, we did a survey and asked people, given this was a new virus, given it was a new vaccine, what drove you to actually get the vaccine? And you may be surprised, but what drove people to get the vaccine was the maternal figure in the family. If the mother figure in the family said, we're getting this, then they got it. And so that, you know, I don't know if that was social media, but that again was a trusted, you know, person who said, this is what we're going to do. And so I think we just have to figure out, whether it's social media or some other means, how do we get to those people that can move folks to do the right thing in terms of getting tested when they need to.
So I had a 6-month-old during H1N1 and was in a priority vaccine population, and have already noted that I will not be in a priority vaccine population for COVID because I'm not having another child. So there's a whole bunch of questions about travel and flying and hotels, and I don't know how much you want to get into that, but then there's also some questions related to, you know, ways to make that more safe, going through TSA checkpoints and things like that. So what have you all been thinking about? Have you, you know, sort of at the county level put out that level of guidance, or, you know, where are you on that?
We haven't put out guidance for people going on an airline or airplane flight. We actually still are at a place where there's still a lot of stay at home in terms of the orders from the state, even though there are things reopening like hotels for tourism. And we still have been recommending that people pretty much stay in their local area as much as possible and only travel if it's essential. We have continually recommended, you know, of course, the hand washing and wearing face coverings. And it is required, I believe, at LAX now to have a face covering when you're going through and when you're on the plane. And then many of the airline companies are also, you know, trying to figure out what they're going to do. But the distancing piece is the hard part on the plane, you know, given what's needed to actually for the operation to run. So people really do have to take, you know, their precautions in terms of going on a plane or doing any other travel. But at the moment, we still think that there's a lot of COVID around, may not have been identified, and you know, we recommend, you know, to stay at home or close to home as much as possible.
So there's a question about the politics of public health. You know, there's been a lot of, not a lot, there's been some news lately about, you know, public health officials, threats to public health officials. I think it sort of varies across the country, the relationship between public health officials and local officials. I don't know if you want to comment on any of that, any of that. Just at a 10,000 foot level.
I've heard it from all of our colleagues. You know, many people are upset, don't understand why they can't reopen or can't do something. You know, we get lots of questions from the public, as well as from our elected officials. But in general, we do the same things that we do with the public. We try to give our data, we try to give our understanding, we try to explain, why things are a certain way. And we've had the support of our board, thus far in terms of the reopening. And so we're very appreciative of that. But it really is understanding also that they're in a position where they have constituents who are bringing up things with them as well. And the best thing that we could ever do is to try to give them the best information on how to respond to those things before those things happen, so that they're informed as they're speaking to and, trying to answer the questions or the concerns that their constituents have. So again, I think information is key in this.
So there's a question about how long you anticipate enforcing face coverings in public, and noting, maybe relatedly to the politics question, that Orange County recently ruled that masks were no longer needed. You said earlier you thought masks were probably here for a while.
Yeah, I mean, I think if we have asymptomatic spread and you're concerned that that could continue to go and we continue to see cases, then yeah, I think it'll be here for a while. The way that we've done this is really to talk about source control. The other thing we've done is to talk about, again, protecting others. And then the other thing is protecting the workers who are serving us and doing the things that we need. And so in that instance, we've had the support of our board to require face coverings when you're going into a business, or if you're going to be out and about and potentially in close contact with either a coworker or the public. And so, I think the question is what are the things that are needed in order to slow the spread of this? And if we continue to see cases wherever we are, then those things are needed. So I say that just because, again, we've had a larger number of cases just in general, but those are the things that we've seen once implemented, like in our skilled nursing facilities, actually really did slow the spread of COVID-19 within those facilities. It's also one of the things that we talk about during influenza season. Somebody who comes in that's ill, we put something on their mouth so that they don't spread to others. So I think in this instance, if we continue to have community spread of COVID-19, then that would be the recommendation, in order to continue to slow the spread within the community.
Okay, so we're going to end where we started, because there's a question asking if you can talk a little bit more about racism as a public health crisis. Has LA County declared it as such? And what's again the approach that you all are taking to that?
So the issue of racism being an issue, crisis, emergency, is not something new for us. It has been core in when we did our community health improvement plan related to public health accreditation, and is a cornerstone of how we talk about and how we look at the diseases and the outcomes that we see with them. So for us, it really is something that we've been consistently working on, and we are using this and this scenario to try to figure out what other things can we move forward to try to address that. And I want to say that, I was asked this question before in terms of why it's hard to talk about racism as a public health issue or impacting health in any way. And what I would say is that, anytime racism is brought up, people often go to the individual. I'm not racist. I don't do racist things. I don't see color. I don't, pay attention to that. It doesn't impact my decisions. But when we're talking about racism in this particular instance, it's really about institutional practices, policies, and laws and regulation that are negatively impacting a group that's already impacted. And we have to look at those things to make sure that those don't continue. So as we talk about racism as a public health issue, it's not about necessarily the individual level, but what institutionally and in society we've done that helps to marginalize already marginalized groups that are already experiencing disproportionate bad health outcomes. So we have to pay attention to that, and we have to figure out how we work on that. What's important in that is really using the numbers to understand what's happening. If you can't break down the numbers, you can't see the disparities. And that is a real policy decision, but that's the way we think about it. That's the way we look at it. And it's something that's continuous through our work, and hasn't just popped up at this time, related to COVID-19 or with the protests that have been happening.
Well, I think that's a great place to end. Thank you for your time. This has been a great discussion. I will remind folks that this is the fourth in our series of discussions with Big Cities Health Coalition members about the coronavirus pandemic. Our next session will take place a month from today on July 15th, also at 1 p.m. Eastern, when we'll be joined by Marcy Flanagan, the director of the Maricopa County Health Department, which is the county outside Phoenix, and Dawn Emmerich, the director of the San Antonio Metro Health in Texas. So you can visit our website to sign up. We also have a recording of the first three webinars in the series, as well as today's will be up there later this week. The best way to know about our webinars is to sign up for our newsletter. So please do that. Thank you again, Muntu. It was great to see you and talk to you. Thanks everybody for tuning in.
Thank you. Appreciate it.
Bye-bye.